Now I request Dr. Ravi Bhattina to start his lecture. Dr. Ravi Bhattina is a cardiologist from United States, keeps visiting India, but he has been working in US for the last 40 years or so. So he has a lot of experience. He's a interventional cardiologist turned into CT MRI cardiologist. So he has a lot of interest, and he keeps helping all the laboratories to tune their laboratories for cardiac MRI and cardiac CT. So he is going to talk to you about the value of the cardiac CT and cardiac MRI and show you some very useful examples, because now cardiac CT and cardiac MRI have become very common investigations, and we do it all the time. There are many centers now. So Dr. Ravi Bhattina, for you.
Thank you. I want to get a feel of the audience. You are all practicing internists or fellows? Can I know? That way I could modulate my talk. You're all internists, right? Practicing. You're not cardiology residents or fellows. Perfect. So my talk was made for you guys only, and ladies. Thanks for having me here. Thanks to the organizers for having me here. And it's really a pleasure to give this talk in front of my good friend, Dr. Krishnamraju, who is the, I would say, world authority on echocardiography. So I'm going to keep away from echo with the fear I won't get into fire under fire with him. So I'll stick to recent modalities. My goal is this: in the next just 20 minutes or so, give you a flavor of the newer modalities, and as a practicing internist, where you should use which study. That way it's more practical. It's not going to be a didactic lecture, it's more of a practical lecture. My aim is to highlight the present state of affairs in a day-to-day practice of an internal medicine doctor to use these newer modalities. And it's a smaller audience, so please stop me anywhere. We'll have an interactive session. It's nothing rigid here. So I picked up a few examples, okay, day-to-day examples. First is a lady, 48-year-old, breast cancer, status post bilateral mastectomy, and previous cardiac workup. She comes to you for that. So she had an echocardiogram done, EF of 50 to 55, SPECT scan 72. You are the doctor, they come with two reports, 55, 72, and she needs to get chemotherapy. What to do? Where we go from here? All right? Issues are, EF is the most important, critical that we should know, the exact EF, the right EF. And if she's getting anti-neoplastic agents, we want to monitor how the heart is functioning. Is it going down the drain, or is it able to manage properly? Because that's how we manage or manipulate your chemotherapeutic agents. And which is accurate? Is echo EF accurate or nuclear EF accurate? Where do we go from here? Well, echo. As I said, Dr. Krishna is here. I don't want to say much about echo. It is a great technology. The strengths are, it's non-invasive. We cannot hurt the patient by our technology. And it is fairly available, even district hospital level. I think there are people who can do echoes. So that is very handy. And relatively inexpensive. Can I have a glass of water, please? Also, not only the myocardium, it also we can see the valves, we can see the pericardium, any tumors and so on. So it's a very flexible and very useful technology. Weakness, we need to have experts to do this thing. And sometimes the window, echo window, if it is too small, we are gone. And thank you. But echo is still, I would say, one of the greatest instruments that we have ever noticed in this generation. Cardiac imaging by SPECT. SPECT is great, no question. It is pretty fairly available in this country now. And it is much more reproducible than echo, I believe. But weaknesses are radiation. If you know, our background radiation is about 3 millisieverts in a given year. Normal, everybody. If you exposed a patient to SPECT scan, you know how much? 20 to 25. in my practice, I never prescribe nuclear scan for a woman below 35, childbearing. Okay? So that's one weakness, but it has its own strengths, no doubt. It's relatively expensive and it is limited to only LV, whereas echo or other modalities, they can give you valves and so on and so forth. And it's kind of fuzzy, it's not very clear. In fact, it's called not nuclear medicine, it's called unclear medicine. Okay, that's how the dictum goes. Now, this is my favorite now here. Cardiac MR, believe me, for anatomical analysis, that is the gold standard. Because the resolution is so good, the way you take the measurements is totally different than other measurements. And reproducibility is the top. You know, suppose today we said 72% ejection fraction, tomorrow morning another technician does it, it's the same. It cannot change. It's not fuzzing around. Okay? No radiation and no injection of contrast. That is the big thing in favor of MR. It also gives information about other aspects of the heart, right ventricle, pericardium, valves, tumors and so on. And it is definitely less expensive than SPECT scan. Weaknesses, it's not widely available, it's not all over. But I believe now, I think some of the districts also are having MR scans. That's good news, 1.5 Teslas. Not all patients are candidates for MR because of inherent problems of, because it's magnetic resonance, we cannot use metallic objects, pacemakers or any other prosthesis and so on. So it has some limitation. Patients who are extremely obese cannot fit into the tube. And patients who have claustrophobia, I can't take MR. I tried once and that's it. That was the last time I had. You get very claustrophobic. Have you ever seen how it is? They put you in this dumb tube and there's big noise going all around. You go crazy. So that's one inherent defect. But still, the outcomes are so good. We have to live with it. And all right, a little more expensive. So when do you really want to do MR? When you really need very accurate measurements, and when you are dealing with a patient who came with other tests done, which is kind of if you don't know what's going on, you want a definite diagnosis, go for the gold, MR. Okay? Now that patient I talked about, she ended up having echo we couldn't find, but then at a later stage, she has pericardial effusion, and also she has a second cancer, lung. So that is the beauty of MR. It's not only the heart and valves, we can see the mediastinum, the lymph nodes and so on and so forth. Any questions till this point? Are we together? Are you okay?
How it is possible that
sure.
pericardial effusion can be missed with
Echo
as well as with the
SPEC. SPEC I wouldn't bet on finding. Definitely we can find pericardial effusion. Echo is the greatest tool, no question. But look at how clearly it is seen here too. I'm a little bit biased. But echo is good enough for a pericardial effusion. So in practice, go for echo first. When you have questions in echo, then go for MR, especially for measurements. Okay?
time taken for the
MR?
cardiac MRI.
Anywhere from 20 minutes to 40 minutes depending upon the patient. If it's only for ventricular volumes, 15 minutes. If on the other hand, if you want to look for viability, we have to give gadolinium and then few other sequences. So answer to your question, anywhere from 15 to 40 minutes.
I just add something to that on echo. See, you could mistake a fat for fluid on echo. Both are echolucent. Whereas in MRI, you can make them out.
You can make a difference.
That's one.
Good
Two,
point.
exudate versus fluid. Exudate and fluid looks alike on echo. You don't really know. But you can differentiate them on CT or MRI. So these are the two areas where MRI could be better used than echo. But by far and large, what he says is right. Echo is a good tool. You could also do a transesophageal echo if your window is not good. But for effusion alone, it may not be necessary to do MRI. But there are other reasons why you might do it. One important reason is you should always know the neighborhood of the heart if there is a pericardial effusion. Pericardial effusion may only be a clue to the mediastinal malignancy or lung malignancy, etc., etc. That you can't make out on echo. But you can make out on MRI or CT. So that is the reason why it is significantly more useful.
And resolution is no comparison between echo and MR. MR is the greatest. Next patient, 51-year-old female who came for pre-op evaluation to your office, but she had an abnormal EKG, Q waves in inferior leads. What to do? Is it pathological or physiological? That's always a question, and she is scheduled for surgery. So, yes. So what are the issues? False positive Q waves, is it infarction? If the patient had MI, then patient may have silent ischemia or infarction, we don't know. But if the patient did not have MI, is it cardiomyopathy or something else? So once you find a Q wave, patient is going for pre-op evaluation, we are stuck. What next? What are the choices? Echo, TMT, SPECT scanning, MR, the whole gamut. So that's where we as practicing physicians have to use all these technologies judiciously and get the best out of minimum tests. Just an example, not this patient. This patient, there are the three studies, SPECT versus MR versus pathological specimen. Inferior wall, there is, I don't know, yes. So there is no uptake in the inferior wall. So if that patient had Q waves, and if you do a SPECT, that corroborates with your diagnosis of inferior wall MI. Similarly, cardiac MR is much more specific in identifying scar tissue in the inferior wall. Now this is that patient who we talked about, came with a Q wave. This is the LV, and towards the apex, infraapical area, you find a scar. This is done by giving gadolinium. So once it is there, it's no questions asked. Definitely patient has inferior MI. So when you have pre-op evaluation, when you have questionable EKGs, this is a good test. Next one patient is a 30-year-old male with abnormal echo, and patient had a cardiac murmur. 30-year-old, young person. Well, this person has abnormal echo, and what are the things going on here? Why the RV is kind of big? There are some bands here which could be normal. And what is the real problem? Patient has a murmur, patient has abnormal RV. Well, the MR we can do phase contrast study, wherein we can measure the flow across the aortic and pulmonic. So this is aortic stroke volume versus pulmonic. Aortic is about 77, pulmonic is 154. What does it mean? Residents? There is a shunt. Well, where is the shunt? Can you make out a shunt here? Very clear. Large VSD. So what else do we need to know? Oh, that's it. I wanted to show you another slide where we can also get ejection fractions and stroke volumes. I cut it out because of the time. The next patient is a 54-year-old with atypical chest pain. Comes to the office with atypical chest pains. What to do with this guy? Do an echo. I don't know what this echo means. I hope I won't have Dr. Krishna's feeling. I can't see much about it. Then I do an MR. Nice LV and RV. Looks great. But how can answer my question about chest pain? Good volume, a good size, but what does it mean? We need to do some stress. So, we do a stress dobutamine. You know, in this country, stress echo is very common. I think it's the greatest study, but the inter-observer deficiency is so much. I think there is inferior wall not moving well. He thinks, no, maybe it's okay, kind of a thing. Whereas if you do a stress dobutamine, there's no imagination, it's very clear. There are so many computerized algorithms now, very clearly they can measure the wall motions. So put this patient to stress and see how the wall, each wall is moving. And clearly it shows, compared to dobutamine echo, the CMR, it is northwest. That is, sensitivity and specificity both are better in CMR. Same thing with SPECT. CMR is far superior to SPECT. Now the last patient is 26-year-old with abnormal EKG and abnormal cardiac stress test. Okay, I want you to tell me what you find. This is a MR scan. I want the abnormal EKG and abnormal cardiac. Pay attention to the wall thickness. What do you find? Is any one wall thicker than the other? Septal wall yes.
Cardiolite, they may not know, cardiolite is a nuclear isotope. So what he is referring to is a nuclear imaging, perfusion imaging of the myocardium was shown to be abnormal. Cardiolite is a brand name in US.
Right,
Here we don't use it.
Right. It's a perfusion scan by nuclear scan. So that calculate is abnormal and do an MR, this is how you find. So it is HOCM, as you said, somebody was saying, yes. Okay, so in HOCM, if you give gadolinium, you find patchy uptake of the dye. In contrast to where there is scar tissue related to myocardial infarction, where it is subendocardial, also is related to vascular territory, either LAD, RCA, and so on. Whereas in cardiomyopathy, hypertrophic cardiomyopathy, it is patchy. So in this gentleman or person, abnormal echo, abnormal MR, and also abnormal perfusion. The last patient is a 46-year-old male come to emergency room with atypical chest angina. He had 2 risk factors. So this I want you to pay attention. I'm coming into next one, so-called coronary CT. So this is classical. People ask me, when do you order coronary CT? This is what I tell, okay? When you have somebody who comes with atypical chest pains and 2 risk factors, or typical chest pains and no risk factors. Patient comes with crushing pain, sweating, don't worry about risk factors. Do it. Other side is this one. This person comes to ER, do a CT, matter of 30 minutes, we know it's normal, and he can go home. No need of doing overnight stay, watching enzymes every 6 hours, and so on and so forth. The next few slides I dwell on cardiac CT. Cardiac CT, people should realize the one Achilles tendon of cardiac CT is people are afraid of radiation. That's true. But in the last 5 to 6 years, a lot of new things have come up in cardiac CT. We are doing, Dr. Raju can agree with me, at our institute we are doing a cardiac CT for less than 1 millisievert. Average we are doing 1.5 millisievert.
Even in a child we are doing less than 3.
Right. So if you go to the right, I'm not trying to do some marketing here, should choose a right doctor, right place. Cardiac CT is a good tool to use. Most important, I want you to understand this. I'm sure most of you send your patients for angiograms. Coronary angiogram, invasive angiogram, of course invasive, I don't like it. More than that, it's only a luminogram. You just see the lumen. But the problem is in the walls. The real problem is in the vessel wall. That's what we want to know. CT scores over invasive angio there. It tells us how the wall is, what kind of a plaque. Is it a lipid-rich plaque? Is it fibrous plaque? Is it calcific plaque? I ask a question to the resident, anyway, resident here answer, okay, not for practicing doctors. This is a question. Person with 40% narrowing versus person with 95% 5% narrowing. Who has a tendency for acute coronary syndrome in the given too? It could be wrong, just fuzzing it. The guy with 40%, you know why? It's most probably the 40% guy has a vulnerable plaque which could rupture under stress or whatever and cause acute coronary syndrome. Whereas 95% narrowing guy, he walks 5 steps and he had chest pain, he slows down, takes his nitro and goes on and on and again. Because they are mostly seasoned guys. They know when to stop and when not to stop. Okay? The other advantage of coronary CT is we can do multiple views. You do the CT and then sit at front of your workstation. You can see the heart from back, front, below, above, from inside the vessel to a short axis. That's called IVUS view. We can see the coronary vessels in a transaxial view. That way we can see the lumen clearly. And we can see multiple locations. If we do a coronary angiogram, okay, we took 3, 4, 5, 6, 7 shots, right, back and forth. In coronary CT, you can see any number of views. So that's where coronary CT does better. This is another example, in this. If you do a CT on this patient, beautiful. You can see the CT showed a lesion in LAD proximal. Patient undergoes invasive cath. Very clear. In fact, 2 years ago, Dr. Raju and myself did a study. It's an international study called MEDIC trial, wherein they compared invasive angiogram to CT angiogram. The specificity was like 80%, kind of iffy, but sensitivity is 100%. If you found that there is no disease, in cath also there is no disease. Okay? So that is the beauty about coronary CT. As I said, it's not only the lumen, I can tell about the vessel wall. This person has multiple calcific lesions and one soft lesion. Yes, this is a soft lesion. How do I know soft lesion versus hard lesion? We measure the Hounsfield units. There are certain numbers, which is very easy. Now this is, I would say, the best slide I could ever show to you. Because present day, we want to know vulnerable plaque. That is the culprit. So this is a study recently published. This is called napkin ring lesion. If you find a napkin ring lesion, they are prone for acute coronary events. It is characterized by all round there is a lesion, soft lesion, Hounsfield units of lipid origin, and there is what's called positive remodeling of the vessel wall, and there are some calcium specks. So these characters, if you find in somebody, you can tell the referring doctor, he has to be taken care immediately. Put him on high dose of aspirin, statins, and beta blockers, the whole. And if the lesion is critical, go and put a stent or whatever. Okay, please remember this. This is life-saving. I think I'm almost at the end. CT also is very useful for anomalous coronary arteries. Very easy. All the other studies, echo and regular cath for that matter, I'm telling you, gentlemen, if you find anomalous artery in the regular cath, we are dead. We have to take so many pictures from different angles, put a right heart catheter, see where the coronary is coming from. It's a pain. You just do the CT, right away you know the answer. Okay, this is the last slide. So this is what I want to say. What are you trying to detect? That's what we need to know. There is no one single mantra for these things. We have to customize to the needs of a patient. Anatomy, CTA and invasive angio. You want to check the ischemia, stress perfusion like SPECT scan, thallium scan, or Dobutamine stress echo, or CMR if the echo is not very clear. And this question of previous myocardial infarction, you can do SPECT. SPECT also shows irreversible ischemia. Wall motion by stressing. This is the gold standard now. Delayed hyperenhancement to CMR. Quite a few doctors I have seen in this institution here in Hyderabad. Patient has previous heart attack, comes for cath, he has got triple vessel disease. What do we do? Bypass surgery. So they do a CMR, cardiac MR, to see viability of the myocardium. Suppose the patient has viable myocardium in the LAD territory and scar in the RCA and circ, there's no point in Mickey Mousing and wasting time on the pump time. Just go and fix the LAD and come out. So that way we can do selectively identify the culprit lesion and treat. And CTA is just still not there yet. Thank you. Questions, I'll be happy to answer either here or out.
This is just like amyloidosis or hemochromatosis on cardiac MRI.
Yes, good question, sir. I've seen a lot of scar tissues due to myocardial infarction, but after coming here, in care we have done amyloidosis and sarcoidosis, quite a few sarcoidosis. We do an MR scan with gadolinium, patchy scarring, especially in the inferobasal area. Actually, there is one study where they have shown high propensity for sudden death syndrome because of ventricular tachycardias. So answering your question, yes, there's very good in infiltrative myocardial disease. Yes.
I'm going to show some examples when I speak about it. I have some of our own cases which I'm going to show.
Thank you.